Monty for giving me an opportunity to report my early outcomes and also to show how I do it. No disclosures. The duodenal switch is a metabolic procedure that gives effective weight loss, excellent resolution of comorbidities, but unfortunately is not very common, or fortunately it's not very common. Because it's a very complex procedure, dissection at the head of the pancreas can be difficult, and the dreaded duodenal stump leak of 1.5% put people off. So there was this effort to try and find a procedure that gives as good weight loss with it being less complex to do and also give excellent comorbidities. And I think that led to this modification. Different terminology, SIPS and SADI, based on the length of the common channel, but I believe that at this ASMBS in November, to honor Antonio Torres, it'll now be called internationally as SADI. It is technically simpler to do. The first part is a slightly larger sleeve, which actually the patient compliance is much better. They can eat and drink a little bit more than what you would do in a standalone sleeve. The attachment is to the mid-gut and not the distal ileum like you would do with a duodenal switch. There is adequate bowel, hence no short bowel syndrome. It combines ghrelin suppression and activates the ileal brake to give us a good metabolic response. And so far, with the current literature and data, there has been no evidence of any afferent loop syndrome with this procedure, and there has been no bile reflux for which the rulum was being fashioned with a traditional duodenal switch. Technique, creation of a sleeve. I think all of us know how to do a sleeve adequately, so I'm not going to concentrate on that, but it involves a length of bypass, a 300 centimeter common limb, and a hand suture duodenal intestinal anastomosis. The first step is identification of the ileocecal junction. I use the appendicis epiploica, pull it up and make sure that I see the ileum and the cecal junction. Otherwise, if you pull a wrong loop, you're going to end up in serious trouble. I use Rudolph bowel graspers, and I mark 10 centimeters on both graspers with a steri-strip to make sure that there is accurate measurement of the bowel. The orientation of the bowel is also very important. You don't want a twist, otherwise you'll end up into trouble. So after counting 300 centimeters, I mark the point and stitch it to the greater omentum so that it doesn't slip away. The next is entering into the lesser sac. I find a point diagonally opposite to the incisura to be the most easier point to get into the lesser sac. I use the ligosure to resect the gastrocolic ligament at the spleen. I have not had to use any clips or haven't had any bleeds at the moment. I think dissection of the posterior gastric arteries, which is a branch of the left gastric, is quite important, and if we don't do this, there can be a very large posterior fungal remnant that could be left, and even with a standalone sleeve may cause suboptimal weight loss. I'm very keen to identify the left crus and dissect the left crus to its entirety, where I can see the posterior aspect of the hiatus, and if there are any hiatal hernias, I repair it at the same time. So after this, I concentrate on the medial dissection of the duodenum, the resection of the gastrocolic omentum is continued towards the duodenum. I make sure that I identify the pylorus and at least dissect about 2 to 3 centimeters of the first part of the duodenum. Again, I use the ligosure, and I'm quite comfortable with its good hemostatic properties. The posterior dissection is the key. This is what puts people off, and I think that my important thing that I've learned is to limit the posterior dissection to the gastroduodenal artery, because beyond this point the duodenum becomes retroperitoneal, and you can injure the blood supply to the duodenum. The inferior and the superior pancreaticoduodenal arteries come below this level and form a loop. So if you don't go beyond that, then there is a very, very, very rare chance of causing duodenal ischemia. You can see the gastroduodenal artery coming up there very quickly. The space that is created with this dissection allows comfortable passage of a 60 millimeter purple price stapler. I have never had to take the right gastric artery down, but I do know the European proponents who did the traditional duodenal switch take it down each and every case. Then I get the part of the 300 centimeter marked to the duodenum to do a continuous stay suture to prepare the bowel for an enterotomy. I use the endostitch and a polysorb suture 2.0 to do this. Initially, I used to use a cautery device to put a hole in and also make the enterotomy, but I then changed technique to using a Lycosure so that I get clean cut edges with absolutely nil bleed. The first suture I take is a continuous posterior suture, again using a 2.0 polysorb, and once this is done, an anterior suture to complete the anastomosis. I endoscope each and every patient and air test it for a leak, and also see if there are any hiatal hernias that are left behind in the process. And if you could appreciate the orientation, the right side is the afferent loop, and the left side is the efferent. Currently I've done about 151 SIPS. When we looked at our data for publication, I had done 125, but not to cloud judgment between the outcomes from a revisional and primary. We excluded the revision. I had more females than males. Preoperative weight was about 123. Preoperative BMI 43.2. A good mix of comorbidities, 40% type 2 diabetes, 30% of hypertension, hyperlipidemia, 23 people with preoperatively diagnosed obstructive sleep apnea on CPAP, and 10% of patients having reflux. Skin to skin time was 121 minutes. It has now come down to about 1 hour and 10 minutes with the use of the endoscope. Most of my patients go home the next day. There has been no intraoperative complication or any conversion to open. Short-term complications, I've had two bleeding, one from the enterotomy edges because of the use of cautery, subsequently changed to Lycosure, and one port side bleed. Now, both of them were asymptomatic, but they had dropped the hemoglobin up to 10, and I thought it would be wise to give them a unit of blood and IV iron transfusion, because their ability to eat and drink was going to be impaired for a few weeks. I had one Pickwickian syndrome, alveolar hypertension, or hypoventilation obesity syndrome. This patient was known to have obstructive sleep apnea, was treated with CPAP for 3 weeks prior to the operation, but still ended up having it. We needed to treat her in ICU with BiPAP and then CPAP, and she was discharged home after 2 days. I've had one euglycemic diabetic ketoacidosis secondary to SGLT2 inhibitors use. At that point of time, we had no idea why she had it. Looked up literature. There's about 8 cases in the US that had been reported with this. Subsequently, 2 weeks after this complication, the Australian Diabetic Association came up with the recommendations. I actually stopped SGLT2 inhibitor use the time I see the patient and not just 3 days before. Nil long-term complications. Good weight loss, I've reported at 12, 18 and 24 months. We've had more than 60% follow-up rates at all intervals. They drop their BMI, they lose a lot of their weight in the first year itself. They drop their BMI up to 27 in the first year, go down to about 25, and subsequently at the 2-year mark, they put a little bit of weight on, like they would when the metabolic effect decreases after any bariatric surgery. The change in the BMI units is about 17.8 at the highest, and I've had a mean excess body weight loss of 71.1 at the 18-month mark. Remission of comorbidities, excellent resolution with diabetes, 94.4%, excellent resolution of obstructive sleep apnea with 94%, hypertension, hyperlipidemia around 70%, and there was resolution of 12% of people with reflux. That is because I think they had hiatal hernias and we repaired it at the same time. They were improved at about 37%. I've had nutritional data as well, but due to paucity of time, I haven't put it. We've had about 70% follow-ups with no statistical difference between the pre-op and the post-op nutritional data at 2 years' time.
Well done, Ravi. Any questions?